Katie, Rushi and Liz for joining us this afternoon on the podcast, and we're really keen to understand what you've done differently through COVID and you continue to do to maintain your ambulance handover performance, especially in light of you supporting surrounding hospitals with additional activity you have through intelligent conveyancing. So Rushi, would you like to tell us about what you've been doing?
Thank you, Jenny. So there have been a few things that we've done, and I think the few different things that we've done, they've all come together for us to then make an impact and manage the standards that are expected. So some of the few key things that we've done is recruitment, worked on recruitment. So initially we were struggling with nurse numbers, and we brought in some ECAPs, and we were lucky in that quite a few paramedics wanted to join the team. So we brought in our ECAP team. We then have worked on IT. We've worked on skilling up our ECAPs. Liz has done a lot of work around the initial triage and getting the triage times as per the standard, as per the expected standard. And what that does is it reduces the length of stay of the patient and reduces the element of overcrowding. So that is, so the one aspect is to reduce the overcrowding, is to see patients quickly, assess them quickly, and stream them into the right pathway. So that has happened through the nursing team picking up their triage times, skilling the ECAP team, and then Katie, our care group manager, who also manages the acute medicine group, has worked on pathways, streaming pathways to AEC, FES, and we are now currently, working on the ambulance pathway to some of the assessment units. And also we've worked on our fit to sit area. We've worked on ambulance patients going to our urgent treatment center. So it's been a few things that have all sort of come together for us. And would you agree, Liz?
Yeah, no, definitely. I would agree, and I think it's that sort of early intervention, early risk stratification at the front door, and early intervention from the ECAPs, which has predominantly facilitated our ambulance offload and our journey through the department all onto one of our ambulatory areas.
And Katie, what the ESTEC pathways that you have been working on?
I think for the ESTEC pathways, I think the important thing has been the fact that we have got a push model from ED rather than a pull model from AEC, and the criteria is quite wide of what we accept within AEC. So I think that's definitely helped the flow within ED. I think the ESDEP for Walsall is currently second in the country at the moment, but that's obviously through frailty, SACU, AEC, etc. And then we've had the pathways for the WMAS for 111 as well, so we can have direct referrals to AEC from the patient's home from WMAS to avoid them coming through ED, which has helped with the patient flow, which in turn helps with the ambulance, frees the staff up to see the right patients. We've also got the 111 service that we've been introduced, so 111 first, so patients are encouraged to phone 111 first to get streamed to the right place, which has also helped with the ambulances.
Yeah, so we have really made quite strong steps to reduce the element of overcrowding and getting the right patient in the right place, And so a simple thing like skilling up the ECAP so that they can request some x-rays and also follow some of the clinical pathways means that at the point of initial assessment, they provide the initial treatment that the patient may need, but then we are trying to empower them to make the referrals. And now they are working, since a lot of our ECAPs are paramedics by background, they're actually working with the paramedics who bring patients in and kind of support them in thinking about, or challenging them in some occasions to think about, is ED the right place, or could we have gone down to frailty, or could we have gone down to SACU? So that has helped. And I think culturally, for me, that was one of the big differences, is that culturally, the leadership team, us three, we take full ownership of all patients that are coming into the department, and we actively try and create space, whether it is paramedic waiting to offload, or patients in waiting room, be it the red or the green zone. So actively trying to, taking responsibility, ownership, that once the patient has reached our department, it is our responsibility, and we should make every possible effort. And that actually seeps through to the teams. What do you think, Liz?
Yeah, no, absolutely. And I think building on the working relationship issue with the ECAPS working alongside West Midlands Ambulance Service, we've got an electronic platform in the department. It's called Ask Earl, and we've got QR codes around the department, Jenny, where the ambulance service can provide us feedback around how we're doing as a department, and equally they can ask around cases that they've conveyed to the hospital to check the progress and the appropriateness of the conveyance, and that in itself feeds back into our monthly staff experience platform. So and WMAS have taken up that quite, we get quite a lot of inquiries through that QR Ask Earl platform, which has been fabulous for collaborative working, really. So we're asking for good and bad feedback around how well not we're doing at the moment.
That's really essential, isn't it? That partnership working between the ambulance service and the ED department, and for me, I think, and I'm hoping that there's a degree of ongoing learning through the use of that QR code and an embedding of good practice and confidence that they're doing the right thing. Can I just and it's only my own lack of knowledge. ECAPS, what are ECAPS and what do they do?
So they are emergency care assistant practitioners. So they are the equivalent to a Band 6 nurse. In essence, they will do a rapid assessment of the patient, like a top-to-toe assessment, initiate bloods on arrival. They can request CTs. They've got PGDs available to them. And I think the key element really of their role is that they will stream patients appropriately, but they'll also manage any risk that's coming through the door. So patients that are flagging for sepsis or any patients that need a senior review, that they'll flag those patients quite quickly. Our length of stay in that area is between 30 and 40 minutes, and the patient receives a full workup in that time. So early investigations, early assessment, and if need be, early engagement of senior clinicians. So overall, the patient journey is much improved. By the time the patient arrives into the department, they've received generally a full workup, and they're just waiting to be seen by a doctor.
So it really does enhance that process and expedite the access to diagnostics and some of those key clinical decision-making diagnostic interventions that we need. So what have been the challenges?
Challenges, I think, as with every other trust, COVID has presented a challenge, and it did present a challenge. Just the size of our department, it is really small, and to be honest, in today's day and age, you wouldn't design an A&E department the way our department is. So the initial challenge started from trying to have two routes in, making sure that the respiratory and the non-respiratory patients aren't mingling. Yeah, and having enough staff to then provide the initial assessment for these two streams of patients. Again, we have been, I think, fortunate in that because Katie sits over both our care group and acute medicine, she's always able to have that broader vision and support us in getting some of these patients across, some of the stable differentiated patients. So we and that's our key issue at the moment, is to ensure that the assessment units start functioning as frontline units, and as long as we send them stable, relatively stable differentiated patients, and the nursing team on these assessment units should be able to manage some of these stable patients as well as the on-call team. So that was a challenge. Obviously, everybody struggled with COVID. The disease just progressed, and the pathology just progressed, and staff really struggled as well. But we have been, as a leadership team, we have been able to bring everyone together. What do you say, Katie?
Yeah, I think for me as well, the challenges we have had is because we've improved performance in the department, we're now much relying heavily on the other areas to take the patients from us at an earlier stage. So as long as, like Rushi says, they're relatively stable, so it's breaking down the barriers and the attitudes really that the patient should stay within ED for longer and have X, Y and Z done, and getting them to take the patients earlier really, and taking that risk from ED, because obviously ED is not the place to have these patients. So it's just working with the other areas to get them to take those patients at an earlier stage in the journey.
Yeah, and
I think just to add to that, Jenny, I think one of the biggest things as a department I've seen is we did a perfect week, and in that perfect week it was sort of clear the diaries, and all senior leadership teams were present in the department supporting the teams. There was no additional resource in there. It was just that we looked at professional standards and set the expectation for the emergency department, and it was around performance. But fundamentally, the whole reason for the perfect week was to sort of address post-COVID fatigue and reset the hearts and minds of the staff in the emergency department, to sort of reinvigorate them, to see that beyond COVID, there's a lot more as a department that we can do. And the team have been exceptionally responsive. They have been wonderful. And that was the beginning of March, and the passion and the desire to continue to deliver the perfect week scenario is still there. People of all levels talk about performance and they're fully engaged. So I think from that point of view, that perfect week did what it said on the tin. It did reset hearts and minds of everybody really in the department.
And that is key, isn't it? It's your workforce is absolutely essential in delivering improvement and doing the right things for our patients. And I think COVID has been such an awful time, and to have that leadership, visual leadership, to say we're all in this together and we can do it, I think has been extremely powerful for you guys down in Walsall. So what are your next steps?
So we want to continue on this journey, and I think the key for us is how do we sustain this, the improvement that we've made. We want to sustain the improvements that we made and have more confidence in our systems, in our processes, in our staff, in our skills, in our ability to flex. We want to build the resilience in our system, so that if there are a certain number of people who are unable to, who are off sick or on leave, it shouldn't be that the system then just collapses. So trying to build some resilience, standardize, the pathways, because sometimes there can still be a lot of variability in these pathways. And obviously we are looking forward to our new department, and we are going to have a purposeful made for, the ambulance handover area. Currently we've just put bits and pieces together.
Yeah, I think from a workforce point of view, it's what does that look like moving forward, and will it ever be the same pre-COVID, as in, I know we're not necessarily post-COVID, but now we're coming out of COVID. So what does the workforce look like moving forward, and how do we align that in keeping with national recommendations? And if the workforce isn't out there, how do we continue to be innovative with roles, and sort of be the place that people want to come and work. So that's probably high on the agenda for us as well, isn't it?
Yeah, your workforce is most definitely your most valuable commodity, and that retention and development is crucial in them, in that retention aspect, isn't it? And you're right, it's looking at how you can use your workforce differently, and being brave to use that workforce. And so when's your new build due to open?
So it's spring 2022.
Excellent. So from me, thank you for sharing what you've been through the last 12 months. I think, to be fair, it's quite enlightening to see that you can maintain an improvement journey through such a challenging time that we've been through, and that you've got the reset, and you're looking there for that sustainability going forward. And so on behalf of NHSE and I, can I just thank you for your time this afternoon? Thanks, guys.
Thank you, Jenny.
Bye.